On to the Sheela Basrur lecture, and I have to say, emergency communication is something that, I don't know, just stirs something inside of me. Trust me, I have been through so many things. It doesn't even faze me anymore, but for some people, it's a really, really frightening prospect to be faced with something that comes down the pipe, you have no control over, and then you have to react. Good, proactive planning. We've seen a lot of people go through things. And I think our moderator coming up, Dr. Brian Schwartz, who is Chief of the Communicable Diseases for Emergency Preparedness and Response at Public Health Ontario, is going to shed more light into this topic. Brian?
Thanks, Janet. I hate to break it to you, but communications is everybody's game here. It is a great privilege to be introducing our two Sheela Basrur lecturers this morning. But first, I'd like to say another few words about Dr. Sheela Basrur, who was a friend and colleague to many of us. As a highly skilled communicator, Sheela had the ability to clearly communicate complex public health information during times of crisis. Many of us remember that it was Sheela, the medical officer of health for the City of Toronto at the time, who provided the calm, reassuring voice for Torontonians and Canadians during the SARS outbreak. Her messages were clear, consistent, and vital to building trust in public health. Sheela understood that this outbreak was bigger than public health and focused her efforts on communicating and connecting with different stakeholders in hospitals, community health, and beyond. Her ability to provide leadership and communicate the role and achievements of public health contributed to Sheela's remarkable accomplishments. In honoring Dr. Basrur's unique skills as demonstrated during a health crisis, today we're delighted that our speakers will give us a better understanding of the combination of leadership, communication, coordination, and action that is required during an emergency and which was exemplified by Dr. Sheela Basrur. Okay, the topic 2017 theme is Global Challenges, Local Solutions. And for this session, the global challenge is climate change. We in public health can help mediate global change by our actions, but we are unlikely to stop climate change. Rather, we have to manage the consequences. Climate change is predicted to cause many more severe weather events and emergencies to which public health needs to provide the local solution in terms of a response and in preparations. These emergencies can range from tornadoes, floods, severe heat, ice storms, and wildfires. And certainly here in Ontario, we've experienced everything from Hurricane Hazel in 1954, which I remember, to the 2013 ice storm, frequent heat emergencies, tornadoes in between. Our speakers will provide a unique perspective on this situation in that they had to respond to the Fort McMurray wildfires and the resultant public health challenges they faced during this time. Most impressive that you'll hear is the number of private and public partnerships that were forged in order to orchestrate a mass evacuation and re-entry into the affected region. As we prepare our own local solutions to climate change events, I believe there are lessons that we can learn from their experience. So it's with great pleasure that I introduce our two speakers today, Dr. Christopher Sikora, Medical Officer of Health, Edmonton Zone, and Delmarie Sadoway, Executive Director, Primary Care, Chronic Disease Management, Public Health, Edmonton Zone, Alberta Health Services. Dr. Sikora is a public health physician based in Edmonton, and presently he is the Zone Lead Medical Officer of Health and Associate Zone Medical Director for Primary Care, Public Health, and Addiction and Mental Health. Chris has a passion for system transformation and population health improvement. He spent the day with us yesterday teaching public health preventive medicine residents, and I can attest to his breadth and wealth of knowledge. Del Marie is a senior health leader with over 40 years of progressive experience in healthcare delivery in Alberta. As Executive Director of Public Health, Primary Care and Chronic Disease Management Division, Edmonton Zone, Alberta Health Services, she is accountable for the implementation of public health, primary care, and allied health community programs delivered in 28 urban and rural health centers in the Edmonton area. In May 2016, Del Marie played an instrumental role in the coordination and implementation of her public health and primary care teams, which provided services to the residents of Fort McMurray who were displaced by the wildfires. So today, Chris and Del Marie will present Wildfire at Fort McMurray, Alberta, Local Action Through Leadership, Communication, and Collaboration. Please join me in welcoming Dr. Chris Sikora and Del Marie Saturday.
Thank you very much, Brian, and good morning, Ontario. I hear there's folks listening in and who actually aren't in the room, and we're really pleased to hear the response to the conference today. I can say on behalf of Chris and I, we're delighted to join you this morning to deliver the Sheela Basrur Lecture to open your annual Public Health Conference. We are Alberta Health Services, as you heard, Senior Medical Officer of Health and Operations Leader for Public Health in the Edmonton Zone, which is one of 5 zones in the province of Alberta. And we're going to bring you our experience. This is what happened in providing health care and support to the evacuees of the Fort McMurray wildfires during May of 2016. And Chris is going to start off the presentation, but we will be moving back and forth.
Well, thank you very much, Del, and thank you very much. We're all very pleased to be here today. So standard disclosure, we don't have any association with any pharmaceutical or medical device or communication organizations. So first to start off, where is Fort McMurray? Well, I was medical officer of health in Fort McMurray for about a year, just at the start of my public health career, in a lovely little town of about 125,000 people. It's about 400 kilometers north of Edmonton. On a good day, it takes about 5 hours to drive. On a not so good day, it might take 6.5 hours or so. It's at the headwaters of, or at least that's the confluence of the Athabasca and Clearwater rivers, and it is the home to our oil sands operations, and numerous that draw a lot of media attention. In May last year, there were a large number of wildfires that were present in and around the Fort McMurray environment. There were a number of wildfires that were out of control, and a local state of emergency was enacted on May 1st. We were all watching very closely the media reports and the standard updates and the regular updates that were coming from emergency disaster agencies. On May 2nd, 1823, it stated no real change in fire activity. Winds will determine what comes next. May 3rd, I happened to be at work that day a little bit later in the afternoon. Our Emergency Coordination Center for Alberta Health Services is centered in my own building. And our UCC was established. A call for evacuation of Fort McMurray was made. Everybody north of the Mackenzie Bridge was told to go north. Everybody south of the Mackenzie Bridge was told to go south. With the opening of the ECC, or at least our Emergency Coordination Center in my own building, called for also the operations, or at least the initiation of our emergency operations centers for the zones. North Zone, which helps serve the Fort McMurray environment, and Edmonton Zone, which serves the Edmonton Zone environment. All this was ramped up. This isn't our first kick at the can for emergencies in Alberta. We've had floods, we've had previous wildfires, although this one was quite large. To help support operations, we have an established framework for disaster management. Government of Alberta of course, hosts the Ministry of Health, Alberta Health, and is both the funder as well as a policymaker for health services. Alberta Health Services is the implementer of those policies and the recipient of funds to help deliver services, population-based, of course, but also acute care, mental health, EMS, and numerous other services. So we have an established process which, when an emergency is called, our Provincial Operations Centre opens, which is hosted by the Ministry. We have emergency operations centres coordinated within Alberta Health Services. Site command posts, of course, are always standard. And then our municipalities would also open up their own emergency coordination environments. So to make it a little bit simpler, 3 green boxes are provincial, zone, and then site. And then on, oh geez, I think it's my left, this side, is the ministry, which also is the provincial, zone, and then site. We're interconnected, we're intertwined, we're interdependent. And with that comes the need to have good communication both vertically as well as horizontally. Back to the story of May 3rd. By around 6:30, we evacuated 73 acute care and 32 continuing care patients from the Northern Lights Regional Health Center, our hospital. Put them on buses along with the staff and sent them up towards our one of our northern oil sands operations named Firebag. We have an aerodrome there. Well, not we. Oil sands has an aerodrome there. They're fortunate to be able to land 767s and 737s. Normally it takes about an hour and a half. It took 4.5 hours that day. About a half an hour later, all of Fort Mac was under a mandatory evacuation order. Airport was rapidly evacuating individuals. Residents north of Mackenzie, again, were evacuated north towards Firebag. Residents south were evacuated south towards Edmonton. By 8 p.m., our AHS staff that remained at the hospital were also evacuated. One of our evacuation centers immediately south of Fort McMurray had a couple medical emergencies. We used a rotary craft to evacuate those individuals towards Firebag, where we had a waiting plane. Happened to be working with our emergency disaster management lead, a fellow named Eric Bone, where he made a phone call to WestJet through the 1-800 number. And I remember him stating, "Hi, this is Eric Bone from Alberta Health Services. I have 73 patients, 32 continuing care patients, and about 70 staff members that I'd like evacuated out of the Firebag Aerodrome into the Edmonton International Airport." There's a moment of silence. And then he said, "Yes, I'll hold for your supervisor." and he repeated his ask. The next response was, "Yes, I have a P card." And so WestJet, understanding the situation, scrambled a flight crew and a jet sufficient to be able to hold 180-ish individuals from Calgary to land at the Edmonton International first. We coordinated supplies to be put onto that airplane. The next stop was the Firebag Aerodrome, where there were eventually patients that would be arriving from the Fort McMurray Hospital. City of Edmonton, by that time, had indicated that they are ramping up their reception center at Northlands, and Dal will speak more towards that. City of Edmonton asked, what can we do to help? Well, we asked for transit buses to transport those individuals from Edmonton International. We had 10 EMS units. Usually we don't have that many sitting at the airport. We do have a hospital bay at the airport for medical evacuation. But we had sufficient transportability to get patients from Edmonton International into the city itself, which is about a 20-kilometer drive or so. Yep.
I hope you can hear me. If I stand over here, is it okay? Yeah, so I can see the slides? Great. So as you heard from Chris, City of Edmonton was actually one of many municipalities that was approached behind the scenes by the Alberta government, tapped on the shoulder, could you set up a reception center for evacuees? And they stepped up to the plate with Northland's Expo Center. And at that time, on May the 3rd, I was also in an emergency operations center for Edmonton Zone. Chris was at a center that was ending up to be the provincial AHS Emergency Command Center for the whole province. But I was in the one for the Edmonton Zone, and they were working very actively to find space for the acute care and continuing care patients. But I knew very quickly from some other experiences we had with Slave Lake, we were going to have to actually take care of thousands of people fairly quickly. These 100 were dealt with within 12 hours. They were transported and settled. And I started to email to my directors. I have 5 directors, 3 are public health directors. I started emailing them. They'd gone home already, just about the time they were leaving, and saying, we're going to have to set up a reception center, we're going to have to man, I believe, an ambulatory primary care center, and I'm going to need your help. And sure enough, just before midnight, Edmonton, the City of Edmonton, announced that they were going to set something up. They opened their gates. They have a huge parking lot. They're a huge conference center. And I started calling them, trying to reach them and offer our assistance. It was really important to acknowledge the Red Cross, who's always present in emergencies, and they provided the registration for all the evacuees. Eventually, 16 reception centers were set up in the province, and the one at Northlands was, I believe, the largest. So a lot of support came from the city in Northlands, including places for people to sleep and food. They have great kitchens there because they do weddings, banquets, graduations, so they had staff and the facilities to feed literally thousands of people every day for many meals. And the insurance companies came on site. That was really important quickly, and social services of various types as well. We'll get into that. Here's some of the fire, the looks of the fire. You've seen this on the news just before people were evacuated. And of course, it was all over the news. It was one of the biggest stories of 2016 in Canada anyway, and it was huge. As I said, I called my public health directors first of all by email and then by phone, and told them to meet me first thing. There wasn't much sleep that night. In the morning, I actually told my boss I was going to do this, and she was so busy, she just says yes. She was in the provincial ECC. And I thought to myself, well, from other types of emergencies like this, the type of service we required, EMS, we needed them for their mainly triage support. We weren't going to have a lot of, we didn't think, really ill people. They would go to the hospitals and to emergency, but a lot of people left home with chronic illnesses. They didn't have their medications with them, and we knew they were going to need some help. Pharmacy was going to be really important. Addictions and mental health, home care, and you can see infection control because of the numbers of people on that site, environmental health inspection and support, and allied health like respiratory services. And you can see we set up a model of care with my 2 directors. They literally walked in with nothing, but I had called ahead, made the connections with the City of Edmonton lead, Rob, and they knew who to speak to. He knew to designate space for us, and then I contacted all the leaders, as you see here, because we're an integrated service. I know all of these folks. We sit at the same senior leadership table for Edmonton, so there's really no divisions. We're one Alberta Health Services, so that's our organizational structure. So I called all the leaders for EMS, home care, addictions, mental health, pharmacy, respiratory therapy falls under me, and primary care falls under me. And so I indicated what we were going to do, and that we were developing this model, who was in charge, and I needed them to provide support and actually to send a leader to the center to meet with, it was Stephanie and Karen, first thing in the morning, it was like 8:30, and to start to work on developing their plan. And they all did that. There was no hesitation, there was no question or complaint, because people had seen what was happening with the residents of Fort McMurray. As well as the services we brought on site, we had a lot of health services available through AHS that were off-site that we could bring people to if necessary. We have one urgent care center. It happened to be located 3 blocks from the reception center. Very convenient. It falls under me. It's open till midnight, 365. And so if people needed x-rays or labs, they needed to see a physician urgently, casts, stitches, whatever, we could have that done at the urgent care center just a few blocks away. We also had emergency services on standby in the Northeast, the opioid dependency program. As I said, other folks. HealthLink, I don't know if you have a HealthLink in Ontario, but I think you have something similar where we have nursing assistance and triage by phone 365 days a year, 24 hours a day. And so they played a very integral role as well in providing health advice to people who are suddenly outside of their regular living environment and looking for a particular service and maybe not going to the reception center because if they had family and friends, they didn't necessarily, once they registered, want to stay there. They wanted a more comfortable environment. But HealthLink also hooked people up who were waiting for surgeries and diagnostic and imaging tests in Edmonton, and they wanted to be sure they were going to be able to go ahead with them, even though they were coming from Fort McMurray and everything else had been disrupted. You mentioned partnerships a little bit earlier, Brian, and it was true. Our partnership with the City of Edmonton and Northlands was integral to us to be able to provide this ambulatory service. But at the same time, the University of Alberta also stepped up to the plate and they provided Lister Hall, a student residence, as another accommodation. And there were many, many hundreds of people who lived there for anywhere up to 2 months, some of them. Concordia University as well provided space and mentioned the Red Cross, the transit already, janitorial services, taxi services. Those are the non-health piece. Some people are wondering, where were the family doctors and primary care in this? And they were very eager to help. They weren't sure what the best thing was for them to do. And so our ZOC, our Zone Emergency Operations Center, I was in there and I was the lead for operations. We met twice a day with the provincial folks by phone. So we were operating 16 hours a day at the beginning, but we had twice daily meetings with other zones in the province and also the ECC, the lead for AHS. And I had one of my managers sit in on those meetings to take notes and to get back to the primary care networks. I don't know if you're aware, but we do have primary care networks in Alberta. There's 42 networks of family doctors in the province. In Edmonton, we have 9 primary care networks. And so I asked one of my managers, as I said, to sit in and to call representatives, the group of the PCNs, every morning and update them on what was happening. And what we needed really was for them to take patients who needed to see a family doctor quickly over the course of time that they were going to be staying in Edmonton. And they were very willing to do that. It was easier for us to send the patients to them where they already had an established office. Most of these people did have transportation. They had driven in from Fort McMurray in their own vehicles, rather than having doctors coming and going into this quite impermanent, and it didn't always have everything they required in terms of supports. So, sorry about that. So that worked really well, and they were very, very keen to help us. We did have a psychiatrist and a pediatrician from Fort McMurray who wanted to see their own patients in Edmonton. And the primary care networks and AHS were able to set up for them offices that they could use, and they could call in their own patients off-site, and that worked extremely well. In addition to that, we had to have a very good connection to pharmacies. I had pharmacy folk come in, and they were able to track prescriptions and dispense to people who were short of medication for a short period of time, for about the first week. We really didn't know how long people were going to be staying at the reception center, and it ended up being quite a bit longer than we thought. And we connected with pharmacies in the area to the reception center that were close, that would provide a streamlined service to people who needed medications, even though they hadn't been patients at their pharmacy before. And that was important to have that set up really quickly. a language line. We had a lot of folks actually who didn't speak English. There were foreign workers who'd come in and they had no family in really Alberta. They often didn't speak English well. We also had in-person interpreter services for health needs. We connected with some dental clinics because we did have some emergency dental needs arise. There were folks, Alberta Blue Cross came on site to be able to provide information support to people who were on that plan about how it was going to work for extra costs that they had. People who were disabled or handicapped on assured income, we wanted to be sure their finances were maintained even though they weren't living in their homes. And so AISH came on board and connected with us and was assisting there, not just in Edmonton again, but in Calgary and other locations. We required some supplies and equipment, and we had to lean on our regular suppliers to bring it out to us if it was required at the site for people who were not mobile. It really, everything happened in one day, but at the same time, all this planning was taking place, and all these people were coming to set up shop basically at the reception center. The provincial state of emergency was declared by the Premier. And as you know, 82,000 people left Fort McMurray and the surrounding area. We were very fortunate. Nobody lost their life or their lives due to the fire. 2,400 structures were destroyed in the fire. And again, some photos of that were taken as people were leaving Fort McMurray on May the 4th. And this is more as the fire became contained and controlled, what the first responders saw and the first people who, Chris is going to talk about reentry, but what they saw when they returned. Going back to Northlands, we did have an outbreak, and we had a GI outbreak on May the 8th started, and we had to move our primary care kind of ambulatory type clinic to a new space, and we had to create a sick bay. And we had to keep, obviously, the two groups of people separate. You can't see it very well in here, but there were separate staff taking care of the sick, and we couldn't force people to stay, but we really asked them to stay for a period of time until they were feeling better. We set up special toilets that were incinerator toilets in the sick bay. You might be familiar with that. And on the clean side, we had the other regular staff working with the chronically ill or the more frail. You probably don't know all these towns, but they're surrounding Edmonton, these municipalities, and all it really shows on this graph is that of the 82,000 people who left Fort McMurray area, 43,000 and a few ended up in Edmonton and surrounding area that we needed to be concerned about and providing care and service to for several weeks. So good news travels fast. On May the 7th, I think we had 2,000 people staying overnight at Northlands, and by the next day, when everybody realized there was a GI outbreak, many of them found other accommodation, which was good, probably more comfortable, and it dropped down to 597 people staying overnight that night. And I mentioned we relocated to a larger space. We also had 60 people staying at Concordia University, which was just a few blocks away, and they also had an outbreak declared there. And I mentioned Lister Hall. Lister Hall had a very nice setup. Because it was a student residence, there were separate rooms with bathrooms, which was great to try and control some of the spread of various bugs. We didn't set up a full-flown reception center ambulatory clinic in the same way. Instead, we had public health nurses available basically 7 days a week, and they were providing wayfinding. People were looking for a family doctor, a pharmacy, a drop-in daycare, where could they get groceries, you name it, anything they needed, we would help them with that. And we also had mental health services available for folks who were dealing sometimes with a delayed response to this emergency. And they stayed on the site for quite a period of time. Red Cross was the lead, as I mentioned, for registering folks, and by May the 14th, they had already announced almost 54,000 households had registered across Alberta with them. And within that period of time, about that time period, 10 days later, over $51 million of financial aid was distributed to over 49,000 individuals who checked in. So that was pretty tremendous in a very short period of time. Some of it came from across Canada, some of it was government funding. I mentioned about the drop in the evacuees that continued, and by the 15th, we only had 200 people staying overnight, and but the interesting thing is thousands of people would come back for the meals. Because this had been a banquet center and they were serving breakfast, lunch, and dinner, people just kept coming, and so they just kept cooking, and there was really no stopping it for another couple of weeks. And we continued, we reduced our ambulatory clinic. We didn't need pharmacy and respiratory care and home care on site any longer. By that, it was about almost 2-week period, we stopped and just moved again to public health nurses and mental health staff providing care. So I'll turn it over to Chris.
So with the initial incident over, our attention turned to how do we actually help support reentry? How do we actually start that recovery phase quickly, consciously, and thoughtfully? So by May 14th, we built a hospital. So those series of tents that you see in the image there are portable isolation containment structure, what we call the PICS. 6,000 square feet, 30 air exchanges per hour, if I recall. Full laboratory services, X-ray integrated. The semi-trailer that you see there has a CT scanner. And this thing has an operating room, which thankfully never had to be used, but it's there. With planning for reentry, you have to plan to have service provision or health service provision for people who are going to be in the environment. This was a town of around 100,000. People who would be utilized in the town for the foreseeable future would be workers. How do we adequately plan for health service delivery for those workers who are going to be intimately tied to the recovery operations? So meanwhile, back at the ranch, our GI outbreak was closed. No new cases at Northlands, no new cases at Concordia, no new cases at our Lister Hall site. Had just over 100 cases at Northlands. Lister had around 83, and there were 8 cases at Concordia College. Later in May, we decommissioned the Northlands site. There was at least 1,300 Fort McMurray evacuees who sought health services between May 4th and 27th at the Northlands Reception Center. Most highly utilized resource by the evacuees was pharmacy services. About 1,600 prescriptions delivered to about just around 800, 850-ish individuals. EMS, if I recall, I believe served around 400, and they transported, I think it was a handful.
Few.
Very, very few. Our PICS tent here had, yes, this is the operating room. See, we have an incubator there. We could have handled the delivery if we needed to. More details around the field hospital. While the hospital was at least starting to become recommissioned, we had this enacted and we had this ramped up and utilized. Naming it the Urgent Care Center was, I take responsibility for that because the acronym ends up being Fort Muck. Although FUCC really wasn't much better. It's important to have a sense of humor during these events. Hospital restoration was an ongoing issue. It was something that I did start the day after the event itself, just to indicate that the recovery phase has to start early. So in phase 1, ceiling tiles were replaced, ventilation, water systems were all thoroughly completed. Plumbing, electricity, walls replaced, carpets, linens, carpets, curtains, towels, and all the medical equipment was cleaned, tested, and recertified. And thank goodness that carpet is gone. I mean, I was there, it was 1980s, it was awful. Population reentry, June 1st, 2016. It's a big welcome home. It was fantastic. Welcome home to over 80,000 individuals who were evacuated on arguably the worst night of their lives. On the first day of reentry, we had basic health services with enhanced capacity. Our Northern Lights Health Center was open slightly. We still did need the PICS tent. So we had lab, DI, health information was all operational. Our PICS tent remained open to support primary care and mental health, as well as other community services. Psychological first aid, well, everybody who worked there was trained in psychological first aid. We had mobile community wellness teams. See, you can see the Fort Muck acronym there, FMUCC. Thank goodness we had that M. Carrying on with the reentry, limited public health and home care services were ramped up, and the gradual return of our non-Alberta Health Services community primary care services. Our primary care folks were hit hard with this. Many of their homes were destroyed. Offices had to be abandoned, much like every other business in town, but these are our independent contractors, our primary care physicians. We supported them in their reentry. Full public health services were implemented in mid-June. The entire hospital was turned over to Alberta Health Services on June 7th, 2016. With that turning over of hospital environments came augmented health services, inpatient beds, our ICU was ramped up, full obstetrics, full pediatrics, and then the gradual return of other community primary care services. During this whole time, our environmental public health officers were busy getting the environment into shape. The air was not good the entire time. We had exceedances in air quality standards most days and most hours of most of those days. The entire water infrastructure was down, had to be flushed, cleaned, and recommissioned with Alberta Environment. Food had to be disposed of, both in homes, stores, as well as restaurants. A vast quantity of new stock had to be brought in, and again, for a city of over 80,000. The housing stock of Fort McMurray was severely damaged. There were over 2,400 buildings lost. The toxic ash that remained after the fire itself we had to do a risk assessment on that, and the decision in collaboration with the provincial government was that it had to be bound into shotcrete of some sort and then hauled away and disposed of, thereby reducing risk to individuals upon their return. We had to work with the utility companies to make sure everything from a sewage and natural gas perspective could be recommissioned safely. On phase 4, we had comprehensive health services. Everything's a go. All health services at our hospital were restored, continuing to enhance our mental health, public health, and home care services during the time period, and the ongoing support for return of our primary care partners, and the eventual repatriation of our continuing long-term care patients on a prioritized basis, really on what we could provide within the community itself. Yep.
Thanks, Chris. So just taking you back a couple of weeks from the full operational availability of the hospital that was June the 21st, but just taking you back to June 10th, and people were already returning, and the ones that were returning were often folks who own their own businesses. They really needed to get in there. They were pushing hard to get in to see what kind of damage was done, what they were going to have to do to remediate when they could start work again. but people returned on a graduated basis, and because of the air advisories, I just want to say this, the air and the ash and so forth, those advisories did speak to people who shouldn't come back. People with young children, pregnant women, people with chronic lung, heart conditions, those folks who were frail, we really weren't urging them to come back quickly. Around the 10th of June, the growth in the Fort McMurray fire was 73% contained, you can see that, and it was estimated it had really destroyed 1.5 million acres of vegetation. There were still 17 active wildfires in Alberta on that day, but that was the only one that still was, it was being contained, but it was still of concern. You can see almost 1,600 firefighters were involved in the work to contain this fire, and they had the support of a lot of heavy, helicopters, tankers, and other equipment. And the monitoring, as I said, by public health and the both provincial and AHS was ongoing. Looks like I'm going backwards, but the reason I'm doing this is because although we decommissioned the large reception center within 4 weeks, there were 200 people who did not want to leave the reception center. They really had no place to go. They were not wanting to go back to Fort McMurray. Some of them had some ongoing health concerns, physical and psychological, and so we moved many of those folks over to Lister Hall. But once they were in Lister Hall, the university was happy to have them for a while, but then they had some competitive gymnastics and other events happening, and their student residence was already booked up to take folks for these competitions, and we had to find other locations. So we did provide that public health and mental health services, I said 7 days a week until the 4th of July, and then on the 5th, by that time we had to have other places, spaces for these people to move to. They couldn't stay on a permanent basis. In just Lister Hall alone, we dealt with 2,700 health requests, and so that talks about the needs was higher for the people that were living there. Many of the people there also had children, so it wasn't just individuals, but mums and dads with kids. And early on in June, a lot of the fathers were going back to work at the plants, but the schools were closed. The mothers were often staying with their children in the city because, they had to get their bearings, and there was really, for many of them, nothing to go back to yet. It wasn't really safe. One thing AHS did set up on their webpage was an advisory and information for the public, what was happening in Fort McMurray, and advice on risk issues, what they needed to be aware of. And we did have a lot of views. There were over 62,000 views. It was up from, as you can see, the beginning of May to the end of August. And the busiest day where people were really trying to find out what to do and where to go was the day that the provincial state of emergency was declared. We did take it down at the end of August, but really had good response to it. We did learn quite a lot. I mean, we've only touched so briefly on what was happening, but one thing we did really need, and you can see that not just the relationship with the Red Cross, with the City of Edmonton in our case, Northlands, and all these providers, both health providers and non-health providers, we had to make sure we had those relationships often were already existing, and internal, the people I called on from pharmacy and home care and primary care and all of these other folks were people I already knew. They were part of our organization, and they were very willing to do whatever they could to help and to assign people on an ongoing basis until we didn't need them any longer. I would say one of the successes for us is getting up and running within less than, 12 hours, get things in place, which was quite an amazing task now when I look back on it, is we used our management hierarchy, our organizational structure. And so we only have one CEO. I think I might have mentioned this for Alberta Health Services for the whole province. And she formed the ECC and then the zone committees simultaneously, as you already heard, by 5 o'clock on May the 3rd. And people were just getting notified probably at 2:30 at Fort McMurray that things were in bad shape and they were going to be needing to leave the community. So our communications folks were a big part of our emergency command center for the province, but also for the zone emergency operations centers. As I said, I spent every day there for basically 4 weeks, and some days were, 16 hours a day. And communications, we're in constant contact with them, not just for getting messages out to the public, but to government. There were committees between AHS and the government emergency folks, and that was really important. Also to our own staff. When we went into the reception center, I probably didn't mention this, but IT was really important. This big conference center with their cement walls, we were not getting good reception on the phones with emails and phone calls. So we had to have hard lines put in for computers and also for phones so that we could reach each other and talk to each other, because I needed to talk to my leads there on an ongoing, or email them on an ongoing basis, and vice versa. They needed to reach out to lots of people off-site for supplies, for staff schedules, for various things. And so it did help us. Whatever your management hierarchy is, you need to use it. And people need to know. That's why we really support incident management training. All of my managers, directors, myself, everybody has at a minimum ICS 100. Some have a higher level, which is great, but then they understand what a command center is. They understand how it operates in an emergency. They understand this isn't we're not going to take a vote and have a discussion on everything that needs to be done. It's going to be a command and control kind of military situation, and we need people on board that are going to know that and are going to be able to do what's required and follow direction. They also, I had some very good directors, I have to say, but I had to be careful not to wear them out. Once you're in that reception center, creating it from nothing, you walk in with your hands, and we've sent the people to them, and then they're ordering what they need. And those were like 16-hour days. After a few of those, they're exhausted. So I had to be sure to bring in other management staff from home care, for example, who could spell them off, and they set up schedules, and that was really important. The multidisciplinary team, I said we set up an ambulatory clinic model. We developed this from our own experience. You might, if you were doing it, set it up differently depending on your event and your environment, but that was extremely important. And we knew that it wasn't going to be just one type of provider that was going to be necessary. For primary care, we really support a multidisciplinary approach always. You heard from Chris, set up temporary healthcare facilities, not just at the reception centers, but also in Fort McMurray, because of the number of people who were working there and fighting the fires and were first responders, and literally 1,600 of them. And we did have some volunteers, but of course we had to be careful that they weren't doing jobs at the reception center that unionized staff would be required to do. We did have some staff working, frontline staff working obviously on shifts, to try to reduce any overtime, and we had a lot of people volunteering to swap out their regular work in order to take this on in public health in particular. Talked a bit about staff safety. You need to make sure they get fed. There needs to be food. Everybody was concerned about the evacuees, but you need to be sure that that your staff are getting water and fed and some rest. And that can't be underestimated, because they want to do it, but they're human and there's limitations. As well, we had an up-to-date, it goes without saying that we needed to have great management staff, and as I said, I had two of my excellent directors running that reception center from the start and organizing things. I had full confidence in them. They'd had a lot of experience more with infectious diseases, we had a meningococcal outbreak in, I believe it was 2000, and we had teenagers dying, and we had to set up clinics and immunized 142,000 people with 4 days planning in about 10 days. So they've done infectious disease work before, but they hadn't done as large a kind of natural disaster work in Edmonton as this. We have an up-to-date emergency list. Thank God for cell phones and email, texting, it's so important, but it didn't work well when you have cement walls. Surveillance, you can't say enough about the importance of always being aware of what's happening within your environment and what might be coming next. And weather is, so extreme at times now and can be such an important event and can precipitate, of course, all of the aftermath. It's the start of often these disasters or these emergency situations. So that I've come to the end of our formal presentation. We do have several references, but I think there's going to be opportunity for questions as well.
Okay, thank you. Have a seat.
Okay, thank you.
Thank you very much for a tremendously enlightening and informative presentation. There, we have almost 15 minutes for questions and discussion. So I will ask if folks can line up behind the 3 microphones. I just have to spot them here to get ready for questions. Number 2 is in the middle here. I can see that one. And 1 is to the left, and 1 is to my left and your right, and 3 is on the other side. So if you have any questions, please line up behind the microphones. And while people are doing that, I have a couple of questions. First of all, we talked about, with Sheela in particular, that, communications, and what a great communicator she was. You talked a lot about the communication among agencies and among different organizations. How about communication with the public? Who communicated with the public, and how did you ensure the public health messages were getting out and being received?
Well, actually, there was communication happening on many levels. I hope you can hear me.
Yeah, the mic's on.
AHS had their website, and they were often making announcements to the media. The media can be your best friend in terms of getting information out, but the provincial government had a very important role, and they had their own emergency preparedness committees and structure. And they were, for example, the Premier had to announce that it was an emergency situation and declare it as such. So what helped there was, as I said, these joint committee meetings every day between the provincial government and Alberta Health Services executive level. So they were meeting and discussing key issues, and they would decide who was going to put out the information so they weren't tripping over each other, particularly to the public. Then as well, we talked about the zone emergency operations committees. There was 5, 1 for each zone. We were the Edmonton zone. We met twice a day with our counterparts and our ECC. And it was often that we would say to them, we have a question on something that's coming up in a particular issue. Can you take this to the government when you're meeting with them? So everybody wasn't inundating the Premier's office or the Minister of Health's office, or it was funneled. There was a hierarchy and a way to do that. So it wasn't us specifically that were communicating, unless they wanted Chris to give an interview as the Medical Officer of Health for Edmonton. It was funneled, and it was often decided by the executive AHS and the provincial government who was going to be doing the speaking.
And within the confines of this room, did you feel the messages got out accurately?
I think the messages did get out accurately. Once a decision was made to proceed down a particular pathway that was consistent throughout both our Alberta Health Services organization, but also within the province of Alberta, the government of Alberta, as well as all the partner agencies. When the decision's made that reentry will occur on a particular date, that's a consistent message. Okay. That's not something that AHS would have normally have been communicating about. Rather, we would nuance and deliver messages around health risk, health concerns, and where individuals could access that health service, those health services that would help make sure that their health could be maintained in the most appropriate way possible. We did a lot of media on the GI outbreaks. It's a local issue, and that's something that we did have to respond to with established messaging that we're all very comfortable with.
Okay, thank you. Okay, over at microphone number 1, please identify yourself, say where you're from, and ask your question. Thanks.
Hi, Heather Manson, Public Health Ontario. So you mentioned about vulnerable populations, and we heard in the media that there was an impact on First Nations populations. So I'm just curious to know how the response responded to the specialized needs of Indigenous people, and how Indigenous organizations were also integrated into the response.
Well, that's a very good question, because you're right. There are a lot of Indigenous people living in communities, some of them smaller, not right necessarily in Fort McMurray, but outside. And they had their own fires being monitored on a regular basis. But with Indigenous folk that we brought in, we had to consult with family and sometimes with elders as to where would be the best place, let's say for the acute care patients and the continuing care patients. I also, so that had to be taken into account, what would be the best location. Sometimes they didn't want to go to these congregate settings, and depending on their situation, we were able to house them in hotels and take care of not just the Indigenous population, but other frail people who didn't quite fit in the standard congregate settings that we had. Now then, we also had FNIB available on site at the reception center. I took many special individual calls from interested parties in the provincial government who were getting concerns from the chiefs about individuals, and we had to work back and forth on a case-by-case basis in some of those situations. We did have communities that they were monitoring the fires like every hour, and they didn't actually have to leave, but they were always getting ready to where were they going to go. And some of these folks did not want to go to Edmonton. It was too big a city, maybe they didn't have any family there. So we had to deal with some of it as for some groups, like groups that were still intact, and their chiefs were their spokesperson, but we usually had to go through other recognized folk who they dealt with in the past in health services. We didn't just barge in and tell them this is what's happening, and there was a negotiated process. So I hope that helps. It was fine-tuned. It had to be fine-tuned.
Okay, thanks. Microphone 3, identify yourself and ask your question, please.
Hi, thank you for the presentation. My name is Elena McIntyre. I'm from Public Health Ontario. I'm really curious, just based on the research that's been done after natural and man-made events such as this, the real long-term consequence for public health tends to be mental health impacts. Given that the one-year anniversary is coming up quite quickly, do you have anything planned to support this population in the coming years?
So that's a really good question. So with the evacuation, our surveillance folks did fix the population, so at least identify as best as possible who was in the geographic areas so that we could track going forward what the mental health or what the health service utilization picture would be for that particular group. That work is ongoing. In addition to that, there are a number of researchers both across the country as well as within the University of Alberta who are actively working to identify what are the health outcomes associated with a disaster like this. We do continue to support any emergent or continuing mental health needs within the geographic area itself, because that's, we got to do that. It's just good health.
There was the government of Alberta and the Premier did make a commitment to enhanced mental health care, not just at the time of the fire and just following, but on an ongoing basis. That is an expectation, because you're right, we can anticipate this is not something that dissipates for everybody quickly, or it takes time. And for others, they get flashbacks and reoccurrences of things that remind them of the fire. I think back to the stories, you probably heard many of them yourselves, but when it was sort of when it was declared that people were going to have to leave, children were still in school. In many cases, school wasn't even out yet. There were parents at work. They were separated. They were trying to get together and find each other, and it was quite hectic and very stressful. Few hours in order to do that. So it did have an impact, and even though the schools weren't burnt, they had a lot of smoke damage. They had to set up some alternative arrangements in the fall for the children in terms of support as well. So it was the whole community really was affected. You're right.
Okay, thanks. Microphone 3.
Thanks, Brian. My name is Ian Gemmell. I'm from Kingston, Ontario. And thanks very much for a nice overview. It seems you had some side dramas going on with your gastrointestinal outbreaks, and I wonder if you could go into that in a little more detail, telling us a little bit about the causes, whether there was a linkage between or I should say amongst the various outbreaks, what you did to intervene, that sort of thing. Thank you.
That's a good question. Thank you very much, Ian. So the day of the evacuation, we did have I guess, somewhat of a passive surveillance process undertaken at any of the reception centers themselves. We were able to identify that it's extraordinarily likely that people came in with gastrointestinal illness that was already circulating around the Fort McMurray environment. Well, that's probably a better media story than people got GI illness at the Northlands Reception Center. It doesn't change the fact that we still have to respond to it. As we did have GI illness at Anzac and several other sites that would at least
My fault, sorry.
well, that would support the hypothesis that there was GI illness circulating in the Fort Mac environment. Within Northlands itself, with having a large number of individuals there, it being the primary check-in center, the environment where insurance, where banking, where First Nations Inuit health branches set up, where you could park your motorhome for free. It being the core center, we did have to ramp up our outbreak management processes, which is active surveillance. It's enhanced cleaning of high-touch surfaces. Northlands trotted out all their alcohol-based hand sanitizers, increased access for hand washing with soap and water. Again, we changed how we responded from a health services process with supporting isolation for individuals who are symptomatic within a separate area, as well as having clean and dirty areas for our health service processes. We were never concerned about the food service. This is extraordinarily high quality professional kitchen that knows how to do health service or food service very well. It was something that we supported, we encouraged, and we defended that quite actively. I ended up being on media daily for about a week around the GI outbreak. And media was very kind to us because we were open, we were honest, we were upfront, we were transparent, we did regular case number updates. And we were quite proactive with what all those processes are that we're doing to help protect our population who are vulnerable and who had just recently evacuated. Hopefully that helps, Ian.
Okay, thanks. Do we have time for one more question? No.
Number 3.
Number 3, yes. Lady, I think there's a lady at 3.
Yep. Okay, one over here, okay?
Okay. Louise Aubin from Peel Public Health. I can imagine after the event there must have been a significant amount of evaluation, how things went, what worked, what didn't work. What was the biggest lesson learned after the event?
Well, we did query ourselves immediately after, and of course we talked about the lessons learned that did work. I think one thing that a couple of things I would do differently, at least from the operational sense for the reception center. I didn't have any support staff on site. I know this sounds minor, but people to assist my directors, and they were really run ragged the first few days. That's one thing. But the bigger thing for me was we had a model now that we think worked. We had developed this model based on previous experience on the fly of what was needed for an ambulatory primary care multidisciplinary team clinic. And we saw, based on, it was a fire, what was required, what were the high use. And so based on utilization and what we had in place, we would copy that model, so we didn't have to develop it from the beginning. Also with scheduling, we had an idea in terms of volumes of people that were at the center we could project if we did this again based on volumes, how many staff we would need on any given shifted. We would be better at the scheduling because some of it was planning and flying by the seat of your pants a little bit for the first day or so. And then you got into, okay, we now know what works and how this has to go forward. But it was a bit chaotic the first day, and I think we would definitely come in with that plan already developed, and it would be much easier to share with folks and to set it up and to convey and to plan it properly right from the first hour.
It's very challenging to pick what is the one lesson learned from all of this. I mean, with our usual emergency disaster management processes, we always have a debrief after every either exercise or after every event, whether it be our Slave Lake fires, our High River floods, even our Ebola practice scenarios that we did numerous times across both Edmonton and Calgary. The debrief is critical. The debrief with the involved parties is something that is so important to be able to ingrain the lessons, ingrain both what the deficiencies are and help improve for the next time. Around Fort McMurray, I think, and I guess around Fort McMurray and around any of our scenarios that we practice, communication and early identification of stakeholders is something that always is a challenge, because there's so much flexibility that can be had around identifying who is going to be involved in a particular response and what their involvement is going to be. Doing that list early on and acknowledging that you're going to have to be flexible is important. And, you know, just listen. Listen to what people are saying, what your community is saying, and what those maybe peripheral stakeholders are saying, because what they are saying is probably going to be very important.
Hey, thank you. I think I would add not just having a debrief, but taking the lessons of the debrief and applying them in your next stage of preparing for the next event. And I think you clearly have done that with your experience in Slave Lake and the floods. So that certainly have applied them in this instance. So hopefully we can take your lessons and apply them to our planning, and we really appreciate you sharing all those insights with us. Thank you, Chris and Delmarie, and I'll turn it back to Janet.
Well, thank you so much, Dr. Brian, for moderating that, and thank you, Dr. Chris and Delmarie. I have to say, I think I speak on behalf of everybody here. We watched, we monitored it online. We had no clue how expansive your response was. I think we imagined it, but when hearing your story, it brought it to life for us in a very, very different way. And on behalf of us here as well, it is nice to know you're back on track and going forward. It's surprising to me that time has passed so quickly that it's almost a year. It's incredible. So please, another round of applause for our speakers.